Okay, let's unpack this. Today, we're taking a deep dive into something that touches countless lives: depression. Specifically, we're zeroing in on what the revision notes you shared tell us about major depressive disorder, often called MDD. Think of this like getting a shortcut to understanding a really detailed set of study notes. These aren't just a brief overview, they're pretty comprehensive, covering everything from the core definition right through to management and prognosis.
Exactly. And our mission here is to act as your guides through this material. We're not just reading it out. We're going to highlight the most important nuggets, connect the dots between different sections, and, help you really grasp the key insights embedded in these notes.
Right, so based strictly on this source material, let's understand this complex topic. Major depressive disorder. Ready? All right, diving in. At its heart, what exactly are these notes telling us when they talk about depression? What is major depressive disorder?
Well, the notes define MDD as a mental health condition. The core features they highlight are persistent feelings of sadness and, significantly, a loss of interest or pleasure in things someone used to enjoy.
Okay.
This isn't just a fleeting bad mood. It profoundly impacts a person's mood, thoughts, and overall functioning in daily life.
And the notes break down how this is formally identified. How do they classify it?
They do, using criteria from two major systems. First, they mention the ICD-11. That requires either a depressed mood or that loss of interest lasting for at least 2 weeks.
2 weeks, okay.
Then they list associated symptoms like reduced concentration, feelings of guilt or hopelessness, thoughts about death or suicide, changes in sleep or appetite, noticeable changes in physical movement or speech, what they call psychomotor changes, and fatigue.
Got it. And the other system?
The DSM-5 criteria, according to these notes, are similar but require at least 5 symptoms present over 2 weeks. And importantly, one of those 5 must be either the depressed mood or the loss of interest.
Right, one of the core two.
Exactly. The symptoms they list here include changes in appetite or weight that slowed thinking and movement, fatigue, guilt, and thoughts of death or suicide.
So it's a specific collection of persistent symptoms they're looking for. The notes also categorize how severe it might be.
Yes, they spell out a range of severity, from subthreshold symptoms, meaning some symptoms are present but not quite enough for a full diagnosis,
Okay.
to mild, moderate, and severe. They also specifically point out chronic depressive symptoms, which persist for at least 2 years.
And the overall picture of its impact, what do the notes say?
The notes are clear here. It's described as a very common psychiatric disorder with significant individual and societal impact. Much of the management, they note, happens in primary care. And a key point highlighted is that it's a leading cause of disability worldwide.
Okay, that gives us a solid definition and scope based on these notes. But moving beyond what it is, the notes then delve into why it might happen, the etiology. What factors do they point to?
Right. These notes emphasize that there isn't one single cause. Instead, it's presented as a complex interplay of factors: genetic, biological, environmental, and psychological.
So, multifactorial.
Pretty much. It's rarely just one thing in isolation.
And they seem to place particular emphasis on the biological side, like what's going on chemically.
They do. The notes specifically call out imbalances in certain brain chemicals or neurotransmitters as playing a significant role. They name serotonin, norepinephrine, and dopamine as key players in the development of depression.
Okay, those key neurotransmitters. Following the why, the notes list factors that might make someone more vulnerable. Who is identified as being more at risk here?
Yeah, the notes provide a grouped list of risk factors under genetic and biological. They mentioned having a family history of depression.
Right, the genetic link.
Certain genetic variations and differences in brain chemistry, kind of tying back to that etiology section we just discussed. Then there are hormonal and life stage factors. This includes hormonal changes, particularly during adolescence or early adulthood, and female gender is listed here as well.
Okay. And the third group?
Then there's a broader category, environmental and psychological factors. This covers things like significant life stressors, having chronic medical conditions, substance abuse, a personal history of depression. Even certain medications can play a role.
Interesting.
They also list lack of social support, negative thinking patterns, and specific personality traits. Quite a wide range.
Here's where it gets really interesting, connecting the symptoms and causes to the underlying mechanisms. What do these notes tell us about what's actually happening in the brain, the pathophysiology?
Well, the notes describe this as a complex picture involving changes in the brain's structure, how it functions, and how different areas connect.
So physical changes, too.
Yes, they specifically note reduced activity in areas like the prefrontal cortex,
Hmm.
that's involved in things like decision-making and planning, and the limbic system, which is central to emotions and memory. And again, they underscore that altered levels of those neurotransmitters we mentioned, serotonin, norepinephrine, or dopamine, are part of this pathophysiology. It keeps coming back to those.
Okay, so if someone presents with symptoms that could be depression, these notes point out that it's crucial to consider other possibilities. What are the differential diagnoses they list? What else might look like this?
Yeah, this section is really important, distinguishing depression from other conditions. They list bipolar disorder, stressing the need to check if the person has experienced periods of elevated mood, mania, or hypomania.
Crucial distinction.
Absolutely.
Mhm.
Other mood disorders like dysthymia, which is more chronic, sort of lower level depression or adjustment disorder where symptoms are clearly a reaction to a specific stressor.
Mm.
They also include anxiety disorders like generalized anxiety or panic disorder because anxiety and depression often overlap. You see them together a lot.
Right, comorbidities.
Exactly. The notes are careful to include medical conditions like thyroid problems or chronic fatigue syndrome, as these can mimic depression symptoms.
Good point. Need to rule those out.
Definitely.
Mhm.
Substance-induced mood disorders are listed, where drugs or alcohol might be the cause. And finally, other mental health conditions like schizophrenia or borderline personality disorder are noted as possibilities to consider.
And separately, the notes list conditions that often coexist with depression rather than being confused for it. Associated diseases.
Exactly. These are conditions frequently seen alongside depression. Dysthymia is mentioned again here, probably reflecting that some people have both chronic milder symptoms and acute episodes.
Okay.
Eating disorders like anorexia and bulimia are listed. Substance misuse is noted as strongly associated. They also list other psychiatric conditions like anxiety disorders, reinforcing that overlap we mentioned, and a range of medical conditions including Parkinson's disease, diabetes, heart disease, cancer, and autoimmune conditions.
Looking at the bigger picture, the notes include statistics on how widespread this is. What does the epidemiology section tell us about its prevalence?
The notes describe it as a prevalent mental health issue. They cite figures like about 1 in 6 people experiencing weekly symptoms
1 in 6, wow.
and a lifetime prevalence around 20%. The estimated overall prevalence they give is 4.5%. The notes specify variations by age and gender, indicating it's higher in older adults and noting a difference between females, 7.5%, and males, 5.5%, in the 55-74 age group.
Okay.
It's re-emphasized as a leading cause of disability, particularly for those aged 18-44. And a really stark number is that cases apparently increased by 18.4% between 2005 and 2015.
That's a significant jump.
It is. And having a chronic physical illness, as mentioned in risk factors and associated diseases, significantly increases risk according to these notes.
Those numbers are quite impactful. So bringing you back to the individual experience, what does depression actually look and feel like? How do these notes describe the clinical presentation?
The notes break down the clinical features into several categories. The most obvious are emotional symptoms, like persistent sadness, hopelessness, or a feeling of emptiness.
Mm-hmm.
Then there's that crucial loss of interest, or anhedonia, not finding pleasure in things that used to be enjoyable. That's a big one.
Right, the pleasure aspect.
Yeah. They list changes in appetite and weight, which can go either way, significant loss or gain.
Right.
Sleep disturbances are very common, either trouble sleeping, insomnia, or sleeping too much, hypersomnia.
Okay.
Persistent fatigue or loss of energy is another key symptom, just feeling drained. Cognitive issues are highlighted, affecting concentration, the ability to make decisions, or even memory. People often report brain fog.
Yeah, I've heard that.
Feelings of worthlessness or excessive guilt and self-blame are noted. Some individuals experience restlessness, irritability, or feeling agitated, kind of keyed up but in a negative way. A critical point they include is suicidal thoughts, recurrent thoughts about death, self-harm, or suicide. Very important to assess. And finally, physical symptoms like headaches, stomach aches, or other unexplained aches and pains are mentioned as part of the presentation. It's not just in the head.
That's a really comprehensive picture based on the notes. How is a diagnosis actually arrived at based on this information?
Well, the notes are clear that diagnosis is clinical. It's made by taking a detailed psychiatric history and performing a mental state examination.
So, talking and observing.
Essentially, yes. They explicitly state there are no specific physical findings that confirm depression itself, but a physical exam is part of ruling out other causes. The process involves assessing the severity of symptoms and how much they are impacting the person's ability to function. How much is it getting in the way of life?
Right.
And importantly, these notes highlight that assessing risk factors for suicide is a crucial part of the diagnostic process. It has to be asked about.
They also mention assessment tools in this section, like questionnaires.
Yes, they describe the assessment as a thorough evaluation. This includes looking at the person's mental state, assessing for suicidal thinking, and considering if psychosis is present. Ruling out those organic causes or drug side effects is essential, as we said. They note the importance of reviewing related difficulties and, with consent, involving family. Past psychiatric history and how they responded to any previous treatment are also key pieces of information.
Makes sense.
The notes list the use of self-report questionnaires as assessment tools, giving examples like the PHQ-9, the Hades scale, and Beck's Depression Inventory too.
Ah, okay, the PHQ-9, that's common.
Very. The assessment synthesizes all this information, considering severity, history, duration, and functional impact, and discussing contributing factors like stress, trauma, lifestyle, and relationships. It's a whole picture.
And these tools help classify severity again. You mentioned severity earlier.
Right. The notes reiterate that severity is classified as mild, moderate, or severe based on how many symptoms are present and how much they interfere with daily functioning. They distinguish less severe, subthreshold and mild, from more severe, moderate and severe, and even provide a threshold for that PHQ-9 scale. Less than 16 indicates less severe, and 16 or greater indicates more severe, according to these notes.
Beyond the clinical assessment, what kinds of formal investigations are mentioned in these notes? Any tests?
The notes list a few types of investigations. There's the core clinical assessment, that thorough psychiatric evaluation we just discussed. They evaluate against established diagnostic criteria, like the DSM-5 we talked about.
Okay.
And a physical examination is included, primarily to rule out underlying medical issues that could be causing or contributing to the symptoms.
What about lab tests? Are specific ones recommended?
The note suggests several laboratory tests may be considered. These include testing thyroid function.
Right. Thyroid issues can mimic depression.
Exactly. Also a metabolic panel, a full blood count, and levels of vitamin B12, folate, and cortisol. In an additional information point, they expand this list, mentioning blood glucose, kidney function tests, UNEs, liver function tests, LFTs, thyroid tests again, TFTs, calcium, full blood count again, FBC, and inflammatory markers.
Quite a few possibilities there.
Yeah, depending on the situation.
Yeah.
They also note other tests like magnesium, HIV syphilis screening, or drug screening might be relevant sometimes.
Is the imaging like brain scans mentioned?
Yes, imaging is mentioned. Specifically, MRI or CP brain scans might be considered for presentations that aren't typical. Or if there are signs suggesting something might be going on inside the head, like unexplained headaches, for example.
But not routine.
Not routine, no. They appropriately caution that specialist advice should be sought before ordering imaging for depression. They also list screening tools again here, reinforcing the use of questionnaires like PHQ-2, PHQ-9, MDI, and QITIs to track severity and monitor how someone is responding to treatment over time.
Okay, this leads us naturally to how depression is managed, according to these notes. What are the main approaches they outline for treatment?
The notes lay out a multifaceted approach to management. It's usually not just one thing. Psychotherapy is a key pillar, including therapies like cognitive behavioral therapy, CBT, interpersonal therapy, IPT, and other forms of talk therapy.
CBT and IPT, right?
Medications, particularly antidepressants like SSRIs, selective serotonin reuptake inhibitors, are another core treatment. They mention supportive interventions, which include things like peer support groups, community services, and self-help strategies. Don't underestimate those.
Good point.
Lifestyle modifications are listed as important, covering things like regular exercise, healthy diet, sufficient sleep, and stress management techniques. The basics matter.
Definitely.
Collaborative care is highlighted, involving coordination between primary care physicians, mental health specialists, and utilizing social support networks. Teamwork. And for severe cases or where safety is a concern, hospitalization is an option.
The notes go into quite specific detail about how management is chosen based on the severity, right? Especially for medications versus non-prescribing approaches.
They do. For choosing an antidepressant, the note suggests considering patient preference, whether they've responded well to something in the past, and cost. Low-dose SSRIs are listed as the usual first-line choice.
Starting low.
Yeah. If that's not effective or tolerated, they suggest trying an alternative SSRI as second line. Third-line options mentioned are mirtazapine and venlafaxine.
Okay, so there's a sequence.
There often is. For non-prescribing management, the notes guide based on severity. For mild depression, they suggest low-intensity psychological interventions, like guided self-help based on CBT principles or structured group exercise.
So less intensive options first for mild cases.
Right. For moderate depression, the notes recommend combining a high-intensity psychological intervention, like full individual CBT or IPT, with antidepressants. So both together.
Combination therapy.
Exactly. Severe depression requires a rapid assessment by a specialist, potentially inpatient admission, and sometimes even electroconvulsive therapy, or ECT, is considered. For chronic depressive symptoms, the notes indicate treatment might involve various therapies, medications, and social or vocational support, with alternative medications considered in specialist settings. It's often more complex.
What about those more intensive or crisis situations?
The notes mention crisis care, home treatment, and inpatient care. They refer to crisis resolution and home treatment CRHT teams
CRHD teams, right?
as a way to provide intensive support at home, potentially avoiding hospitalization. Inpatient care is reserved for the most severe cases, often involving risk. Electroconvulsive therapy, ECT, is mentioned again here as a treatment option for rapid response in severe, often life-threatening depression.
And they mentioned collaborative care being particularly useful for certain groups.
Yes. The notes specify collaborative care is suitable for groups like older individuals, those with co-occurring physical health problems, people experiencing social isolation, or those with chronic depression that hasn't responded well to standard treatment.
So more integration for complex cases.
Precisely. It involves active planning, case management follow-up, and integrating care for both physical and mental health needs. They also add a few more points under additional management info. Regular follow-up is stressed as crucial. SSRIs are reiterated as typically first line. Different strategies for different severities. They mention behavioral couples therapy if relationship issues are a big factor. It's important to consider withdrawal symptoms when stopping medications needs careful management.
Tapering off.
Yes. ECT and other treatments like RTMS, repetitive transcranial magnetic stimulation, and VNS, vagus nerve stimulation, are mentioned for severe or treatment-resistant cases.
Looking towards the future for someone diagnosed with depression, what does the prognosis section of these notes tell us about the likely outcome? How does it tend to play out?
Well, the notes state that the prognosis varies quite a bit. Depends on how severe the depression is, how well someone responds to treatment, and the support they have. Many people do improve significantly with treatment. That's the good news.
Okay.
However, it can also be a chronic condition for some, with a significant risk of relapse, meaning episodes coming back. They list potential complications like functional impairment, difficulty working or socializing, social isolation, increased risk of developing other disorders or substance abuse, and importantly, self-harm and suicidal thoughts remain a risk.
So ongoing vigilance is needed.
Absolutely. The notes emphasize that early intervention and ongoing management are essential for better outcomes.
And the notes provide some specific numbers here on recovery and recurrence.
They do, and these numbers are quite revealing, actually. They note that 70% of individuals with initial subthreshold symptoms will progress to full major depression if untreated.
Wow, really highlights the need for early intervention.
It does. Treated episodes typically last 3 to 6 months. Looking at recovery, they state 50% recover within 6 months and 75% within a year. But critically, recovery rates seem to drop off after that 60% at 2 years, 40% at 4 years, and only 30% at 6 years. So recovery gets harder over time. That's what the figures suggest. Up to 27% may develop chronic depression. And outcomes are worse, according to the notes, with older age, the presence of psychosis, anxiety, personality disorders, or very severe symptoms. Persistent depression is seen in about 10%, and for those receiving psychiatric care, recurrence is very common. 80% experience it, with a median of 4 episodes over their lifetime.
80% recurrence. That's high. Finally, tying back to that risk of chronic issues and relapse, what are the potential complications the notes specifically call out? What are the downstream effects?
The notes list several significant complications. There's impaired social and occupational functioning difficulty with daily activities, work, school, relationships.
The functional impact again.
Yes. There's that increased risk of self-harm and suicide, a major concern that needs constant assessment. Relationship and family difficulties are also listed. Substance abuse is noted as a potential complication, sometimes as a way of coping, which makes things worse. Development of other mental health disorders over time, like anxiety disorders. Overall, it leads to a reduced quality of life. The notes also highlight higher rates of illness and death when depression coexists with conditions like heart disease or diabetes. It impacts physical health, too. Suicide itself is stated as a significant cause of increased mortality, particularly when physical and mental health problems are combined. And finally, they mention risks specifically related to antidepressants, adverse effects, potential increased risk of self-injury, especially early on, discontinuation syndrome if stopped suddenly, and the possibility of triggering mania in individuals with underlying bipolar disorder.
Wow, that was a thorough journey through a dense topic, all guided strictly by these revision notes. A lot to take in.
It really underscores that while the notes provide clear definitions and criteria, the reality of depression, its causes, its progression, and its impact is incredibly complex. It touches on biology, psychology,
Hmm.
social factors, everything.
We've seen the significant numbers on prevalence and chronicity, how it links with other health issues, and that while treatment is effective for many, it's also a condition with a high risk of recurrence and potentially serious complications.
Yeah, understanding that layered approach to management outlined in these notes, tailoring interventions from lifestyle support right through to medication and specialized care based on severity seems absolutely crucial. And recognizing those potential complications really reinforces why this isn't just a mood issue, but a serious health condition requiring comprehensive ongoing care.
Absolutely. For anyone wanting a high-yield understanding of major depressive disorder based on this specific source, you've now got a solid grasp of the core knowledge points these notes contain. So here's a final thought for you to consider based on everything we've covered today. Given those striking statistics on recurrence, with 80% experiencing it, and the potential for chronic symptoms, what does that imply about shifting the focus in care? Moving beyond just treating an acute episode to really prioritizing long-term support and relapse prevention, as kind of hinted at in the prognosis and management sections.
That's a really key point to reflect on. Those numbers, especially the recurrence rates mentioned in the notes, definitely highlight the importance of thinking about sustained support structures, ongoing monitoring, and maybe strategies to build resilience over the long haul, not just getting through the current crisis. It suggests a need for a much longer-term perspective and management.